So we are on week 5 already. It's impressive and amazing how quickly this term always goes. Week 5, probably my favorite. It is cardiac respiratory. I'm an old cardiac nurse from Nicholas Children's Hospital. I opened the unit, worked with a surgeon that came in there, and it's absolute and will always be my first love. My second love is always emergency room. I like the trauma. I'm a trauma junkie. I like the excitement because I'm the calm in the storm. So, week 5, respiratory cardiac. That matching sheet that you all see in the chat box is exactly the things you need to know or understand. Okay. It's going to help you a lot with quizzes and exams. You do have a discussion question and you do have a CJ Sims. I'm a little slow on discussion questions, but I'm getting there and putting comments. And what I'd like you to do is at least once they're scored, go in and look at comments. Like with cognitive delays, one of the comments I put in that Down's children get leukemia and they have problems with hypothyroidism and congenital heart defects. Well, that encompasses a lot of things. And I've seen questions on the HESI regarding that one. So it's in the comments of your discussion. So go back and look at those, okay? I take time to put extra information in there for you. So let's go ahead. Let's start with our PowerPoint. Any questions? Anybody need anything? This is actually a good week for you to
Um,
start.
I was trying to get to the chat and say the chat is disabled. Um,
Oh, 1 second, 1 second, 1 second. 1 second, my dear. I have to stop that. I have to go here. Did you all see the 2 things in the chat?
I didn't know.
Yes, ma'am, it's there.
I think I switched devices though, so that's probably why I didn't
Okay,
see
let,
it.
let me tell you, I'm going to just redo it again, make sure everybody has it.
Thank you.
So that when it comes up to the announcement not working again, you already have it. So here we are, and there's both of them, okay? As in one I made, it was made for a quiz actually for my students, and I've carried it over into a matching, and I think it's a wonderful matching. And there's this PEDS lesson. It's from another professor who also likes cardiac, and I liked what they were saying, so I give you that. I'll try to give you information, but not overwhelm you. Because I could give you a lot, but no, it wouldn't help you at all.
Okay, I got it. Thank you.
You're very welcome, my dear. Okay. Share. Respiratory cardiac. Chapters 40 and 42. So heart and lungs always work together. Just know that. You need oxygen to work the lungs, and then the heart beats the blood through the lungs to get oxygen. So they're next to each other and they work hand in hand. Now, upper respiratory in children. About a child in their upper respiratory oropharynx. They're always full of mucus. They never blow their nose. It's always dripping. They're always coughing. And this is all that upper airway. And then it goes into the ears, right? Now you have ear infections. Lower sort of respiratory infections. These are your pneumonias. It could even asthma is that lower where the air gets trapped. Now, when we talk about upper respiratory, URIs, we think of mostly viruses. Now, the one virus we think about is that virus that talks about your respiratory syncytial virus and your infants. Now, infants are born and they can barely suck, swallow, and breathe, right? Now you put mucus in their nose and they're obligatory nose breathers. And now they're trying to suck and swallow and breathe with mucus. And now you're in respiratory distress. That's why, everybody's like RSV. Oh my goodness, that's, bad for infants. Now, with infants that are immunosuppressed, we're going to go further in this slide. and it goes over. There is a monthly immunization that we give them for the first year of life to prevent them from having it. But when we talk RSV for you and me, it's a common cold. It's just literally a common cold. It's the infants that RSV and it's the dangerous, but it's exactly what we get. Infants just can't tolerate it. Now, babies are born, got all of mommy's good antibodies and antigens and hemoglobin, and they're healthy, right? Well, it all dies and it wears off and it decreases. So, about 3 months of age, most of it is wearing off. And now the baby's being exposed to different viruses, etc. Isn't it about 3 months when you send them to daycare? First, you have 3 months maternity leave, right? And then you send them to daycare. It's right when they're probably more apt to get sick. It's just, the way it is. But what happens is they get these little viruses. Now, with these little viruses, they're building their own antigens, antibodies. We're giving them at 2, 4, 6 months, 12 months, 18 months, 2 years, immunizations. We are trying to protect those children. But actually, the best protection is when they get to be toddlers in preschool, go to daycare, preschools, and all they do is swap spit all day long with the toys. And what are they doing? Virus to virus to virus to virus. I'm getting all of these antibodies built up in my body so that when I go to school, my immune system is strong. And that's where you see at 5 years old, it's mostly bacterial infections because you've gotten everything as a younger child. Increased immunity with age, yeah. More disease, more antigens, more immunity. Now, ear infections, one of the most common of things with children. It's because you have big, wide, short, open eustachian tubes. Think about that oropharyngeal airway and mucus. What happens? All that goes to areas of least resistance. Short, narrow eustachian tubes, and that infection goes up into the inner ear. Normally you have staph in your airway. You just do. It's normal. So that staph goes into the ears and it doesn't like it. And that becomes, your ear infection. They are extremely painful. So there's always a question regarding nursing diagnosis and ear infections. Well, you have an ear infection, you have an ear infection. One dose of an antibiotic is not going to take care of the pain and discomfort. So a big nursing diagnosis would be regarding the pain, ear infection, pain due to ear infection, and you need to give them, their pain medicine. It would always be priority with these children. Now, children sometimes they can't deal with all the mucus and they're chronic ear infections. And that can cause hearing loss in the future. So what they can do is to prevent this, bacteria and infection is do those tubes. So the surgical, many times you'll hear children get, tonsils, adenoids, and tubes for their ears all at once to take care of the ear infection or the snoring or all of the above. And that's what I said. What does a kid look like when they're sick? Upper respiratory, ears, anything. Well, the first thing I always notice is that kid's going to sit in the corner and be quiet all of a sudden. You're like, hello, Bobby, are you okay? I don't hear you. And then they're in the corner, just maybe found their pacifier or sitting there, stuck in a finger or just they're not going to be moving much. They might be holding an ear. They might be whimpering if it's an ear infection, but ear infections may or may not have a fever, believe it or not. And if it is, it's not that 104 type thing. But they don't want to eat. They don't want to drink. They probably, because ear infections are mucus that goes up, you're going to hear that loose, cough. And you might see that nasal discharge, etc. And maybe hear some rhonchi, which is a lot of referred upper respiratory. But kids not eating, not drinking, especially their favorite juice or their favorite food, something's wrong. Now, what is our goal with these children? any child with not breathing right, you want to breathe easier and you want them to have rest and comfort. Rest and comfort, um, when you talk about something like bronchitis, and that's a dry hacking cough at night. That's the one that keeps you awake all night long. You can't stop and you don't sleep. So rest and comfort's hard on that one. In a second, I'll go into treatment for that. Again, any disease, prevent the spread of infection. You get the temperature down on children, they're remarkable. It's like they're not sick. Fever comes down, they'll start drinking, run around, and eating because one of the basic things is hydration, especially if there's a fever, right? And then if there's mucus, you want to liquefy it. Hydration. So keeping the temperature down keeps them hydrated and better outcomes, okay? Now, infectious mononucleosis, you all know this as a kissing disease, right? That's the way we've been taught. It is a herpes-like Epstein-Barr virus. Now, Epstein-Barr is what gives that fatigue, that overall feeling of being exhausted, all right? Now, infectious mononucleosis is actually difficult to diagnose. Now, I'm going to give you a scenario with not a great outcome, but I want you to understand mono. You have a child complaining of sore throat, fever, aches, pains, like flu-like symptoms, swollen glands, armpits, and in the neck, and maybe groin, and maybe a rash. Go to the doctor. They do all the testing. It's all negative. They say it's an upper respiratory, pharyngitis, viral. Send them home. Acetaminophen, ibuprofen, liquids, rest. 3-4 days later, they're still not any better. They go back to the doctor or they go to urgent care. They say, well, you've already done this and that. It's negative, but let's just put you on antibiotics just to try. All right, sounds good. Send them home. 3-4 days later, this is when they end up on Saturday morning in the ER where I worked, and I would get these children. All the symptoms, all the same, still going on. So when we look at that, it's been going on so long, sore throat, aches, pains, all of these swollen glands. We're going to do some blood now. Now, we got to rule out two things. We want a CBC to see if it's viral or bacterial. Now, how would we know if it's viral? White count is normal. If it was bacterial, white count would be elevated. It's simple as that, okay? Now, the other test we're going to do is something called a monospot test, and it tests for mononucleosis. So what happens? It becomes positive, and now we know your child has infectious mononucleosis. It is viral. It's acetaminophen, ibuprofen, fever control, liquids, rest. But the big thing is these swollen glands. Sometimes the liver and the spleen get really swollen, almost like a balloon. So no contact sports. If you, like me, I had 6 brothers in the house that like to beat me up regularly. They would have to be told, no, you have to leave her alone. If you hurt her tummy, you could kill her because it's like pumping a balloon and popping a spleen, popping a liver. So I explain this all to the child, to the father, no contact sports, protect your abdomen. You have to go back, get cleared through your pediatrician. Well, the physician did it to this 9-year-old boy and to this father who had brought him in. Great teaching, send him home. 1 week later, I'm the primary trauma nurse on duty. And we get this call that there was an ATV accident in the Everglades. And when they bring the child in, he was dead on arrival. And I knew exactly who he was because I had him 7 days earlier. And the physician who I was treating him with, his name was Dr. Lopez, me and him were in tears because we had done our job, but still, this child was on an ATV, fell off, hit his abdomen on a rock, and that was it. So it is a kissing disease. The point of me telling you that story is to tell parents, if you ever work in pediatrics or you're ever around mono, the one thing is Swollen glands protect the abdomen, and it's usually 3-4 weeks after diagnosis, minimum, that you wouldn't be able to be in sports, etc. Now, bronchitis. I mentioned this cough, right? The one with the rest. Well, again, it's also called tracheobronchitis. So either name works. It is a dry, hacking cough, non-productive, worse at night, and does not let you sleep. You cough so hard your ribs hurt. Your tummy muscles hurt because you're coughing, coughing, coughing. There's no fever. It is a cough. Now, what do we treat this with? Well, this is the one that you or me go to the doctor and you're going to get a Z-Pack and probably a Medrol dose pack, right? And call it a day. Well, bronchitis with children, we're going to do the same sort of things, but given some sort of cough suppressant. Today, there used to be like these narcotic cough suppressants, but I know that even last year I was trying, I was sick with the cough and bronchitis and et cetera, et cetera. And they don't have the ones that they recommend with like a codeine or something in it that helps, and it would help sleep at night. But there are many other alternatives. It's the cough suppressant that they do need with this. So bronchitis, tracheobronchitis, dry, hacking, non-productive cough. Now, croup. Ever hear a child cough like they're barking like a seal? This is croup. And it's very distinctive, the sound of it. You can hear it. It's also called laryngotracheal bronchitis. Again, another big name. It is croup. Now, croup is oral airway. It gets swollen up here before air enters the lungs. So it's inspiratory problems because it's swollen here. Air gets in, goes out fine, but it's inspiratory, where it's that cough, that bark that you hear that from, okay? Again, mostly due to a virus. Now, that's the other name, croup, laryngotracheal bronchitis. As I said, mostly viruses. Now, this is, this common condition. Children get it frequently. You can really tell they're barking. And it seems like it's benign. The problem is the swelling in the oropharynx, and the coughing causes more swelling, and it could lead into epiglottitis, which is a severe emergency. If we catch it with just the cough, which most of the time we do, we'll give a steroid. It will decrease the inflammation and it'll be fine. But if we let it go on and don't get treatment, it can go into respiratory distress, and it can go into respiratory failure. And again, could go into acute epiglottitis. Now, what is an epiglottis? That's that leaf-like structure that covers the trachea when you swallow, so that you don't aspirate. Well, this thing now, without swallowing or anything, is covered. And I can't get air in. Inspiratory again, no air in. What would this child look like? Well, this child's going to look like the 80-year-old woman with COPD leaning over, trying to find a place in a position where I can breathe. Okay? They're going to have pain in the throat. They're going to be drooling. They can't swallow. But their voice is going to be like, it was all swollen in there. And then, of course, all signs of respiratory distress up to, being restless. And then, of course, it could go into respiratory arrest. Now, what is your job with all of this? You've identified this patient that it's an emergency. There's no airway. Get them to that trauma room or into whichever room is appropriate. Make sure that there's something there that can open an airway, whether it's oral intubation or a tracheostomy tray. That is your job with acute epiglottitis. With that, somehow, with the airway, we've got it open. We have to maintain hydration. This child, epiglottitis, is not going to eat. until it's really, we know the epiglottis has gone down and it's not swollen. So hydration with IV, they're going to put mist aerosol oxygen on because it's easier to breathe in, and that racemic epi initial. And then if we need it throughout, that epi goes directly in and touches, the epiglottis, through a little aerosol. And then, of course, steroids decrease all that inflammation. Now, RSV is also known as bronchiolitis. Again, two names, same diagnosis. This is usually winter to early spring. It's a common cold for you or me, but in infants and immunosuppressed children with, let's say, cystic fibrosis, prematurity, lung disease, cardiac, congenital heart defects, they can't have any more stress on their body. So they have to try to prevent this child from getting this RSV. So we do give an immunization. It's called Synagis or palivizumab. It's a biologic that they give once a month, only for the first year of life. Okay, from winter to early spring. Now we've talked a little bit about TNAs and tubes and whatnot in children. Now, most children today do outpatient tonsils. And as I said, it could be tonsils, it could be both with adenoids, and it could be also with tubes, all at the same time. Some, surgeons and some parents want it that way. Now, how do we teach these patients, these children and parents, how to take care of them when they get home? So no irritating or highly seasoned food. It's going to burn it. Now, let me explain what they do with tonsils and adenoids. You notice those big red little lumpy things at the back of your throat, and the adenoids are a little bit lower. And they literally cut it and cauterize the areas. So what is left post-operatively is scabs. So now you have these scabs that are there. And remember, you're really moist, so they're a little bit, it's gabby, but they can wiggle and stuff can get underneath to the sensitive skin. So no irritating or highly seasoned foods. You don't want to remove that scab because bleeding will start. I've seen a child almost exsanguinate by vomiting clots of blood from tonsils that was 7 days earlier. So don't, protect that airway. No coughing, nothing in the mouth, no tongue blades, no nothing. Tylenol or acetaminophen for pain. Older kids will let you put an ice collar on. It does help. And then some children older, because the ears are right there where the tonsils are, you get poppy ears. So, chewing gum, go up an airplane, it makes your ears pop and release the pressure. Same concept here. Chewing gum may help. Now, you do have pretty bad breath. You've got open scabs in the back of the throat, okay? Takes time to heal. So 5 to 7 days minimum. You're going to smell it and you're going to see that mouth odor, okay? Now, when you have a child who's now going on, it's now 2 weeks, and there's fever and, the smell, earaches, they need to go back to the doctor. And they say with tonsils, you need to keep them calm for at least 1 to 2 weeks. And as I said, the girl who threw up clots like softball size in my triage room, she was 1 week post tonsils. She had just come from the ENT office. So it can happen. Okay, pneumonias. There's all types of pneumonias. Remember, we have all lobes, so any lobe can have it, multiple lobes. And it can be caused by many different types of causes: bacterial, viral, mycoplasma, pneumonia, pneumococcal. And, we do got that vaccine, and we do give that for the young kids too now. Another thing is good old, I love Johnson & Johnson baby powder. I love the smell. I love a baby to smell like it. It's what I grew up in nursing with. Actually, we used it. Well, we found out the powder in the ear we were hurting our children. And I worked in a newborn ICU. So it was one of those things that I don't use powder anymore. Um, Another aspiration could be feeding, right? Reflux. So feeding, how do you feed a child, right? We need to burp them well, not overfeed them, sit them up after they eat, all of those things. And then what if you're doing some heavy cleaning with chemicals and bleach and this and that? The child should not be around it. And I think the one thing, which is any age child for any reason, I know ear infections, SIDS, pneumonias, is cigarette smoke. Should not be around small children. Foreign body aspirations. How do children the world? What do they put in their mouth? Everything. Now, I was given this lecture last summer, and my 9-year-old grandson put a quarter in his mouth, was talking to his mother, and inhaled it, and ended up actually had to go to the hospital and have a bronchoscopy. But you know something today? Usually these children come in, and that's exactly the x-ray that you see. And it's not a dime or a nickel, that's a quarter. They always like quarters because it's bigger. I don't know, but they like them. And it usually gets stuck there, complaining of pain, maybe a little bit of drooling, but usually they're breathing okay. Get the x-ray. Do you know how they take that out in the emergency room so they don't have to go to the OR for a bronchoscopy? This is interesting. They take a Foley catheter with a big balloon, put it in the mouth down below where that might be, blow up the balloon. This child will be sitting on the surgeon's lap, mother holding the hand, me, daddy on the other hand holding him, and say, cough. And as he coughs, he leans forward. They pull out the Foley, and usually there's a little bit of vomit or mucus, and the quarter comes out. And before they pull it, I say, whoever gets the quarter first gets to keep it. If I get it, it's mine. So they push, and you know what that kid does? He jumps on the floor and he gets the quarter and he goes, it's mine. What did I just do? I distracted that child. He had no clue what just happened. His mind was, I get a quarter. See, this is a distraction technique. You can use it, it works. Post after we do this, what we do is we just watch them, making sure they're airway for a couple of hours, and they go home. I've seen French fries kill children because it gets inhaled and they can't breathe. So I've seen all sorts of objects go in, but the French fry was the worst and ended up with the death of a child who ended up on ECMO. And then just normal. The coins come out, they go home, and that's that. Now, pertussis. Pertussis is a immune, it's a disease that has an immunization for. The problem is not every mother or parent believes in immunizations, and that's the right of that parent. But the problem is because they're not vaccinated, they can get it and they can give it to me or, the children are surrounding them. That's in the concern. So there is vaccines. We do give Zithromax is the treatment, and we put them in airflow rooms. They're highly, highly contagious. Now, we don't always know right away if it's pertussis. So sometimes we get exposed before we know. That could be croup, right? Whooping cough. Could be. We don't know. Again, what would you do if you knew? Put a mask on, get the child to a airflow room. Smoke inhalation happens all the time. The thing is, you just re-oxygenate when you get these children. If there's a hyperbaric, sometimes I worked in an adult ER for a while and sent them to hyperbaric when they had, these smoke. Again, tobacco smoke, I'm telling you, it's no good for any age child. Now, cystic fibrosis is a multi-system condition. It's inherited. So both parents have the trait. You have 25% of getting the disease. Now, sometimes we know, and they're testing now, when before the babies are delivered, it's part of that beginning testing. They are testing now for cystic fibrosis. But what if we didn't? And then we didn't know. How would we at birth even have a symptom? The child has cystic fibrosis. This is one of a couple different conditions that causes a child to not move their bowels in the first 2 days of life. Usually it's meconium, it comes right away. You breastfeed and it comes. No, this one, it's not. And that would be that clue to say, hey, something's going on here. And they test them for several things. Now, when we're older, let's say it's missed. Now, let's say we're getting older. What are things are we going to see? You have a child, cystic fibrosis. Number one, it's an electrolyte problem. Sodium is escaping through the pores. It's like you sweat salt. If you told a parent to lick their child's skin, it would be salty. You would literally taste salt, okay? That's how severe it is. Also, it affects the lungs. So you're going to see that coughing, lungs infections. You also giving a lot of antibiotics and aerosols on these children. And there's daily, multiple times a day aerosols on these children and CPT. Again, lung sounds are all over the place. And another thing that this bothers that you've got, it affects electrolytes, it affects the lungs, and it affects nutrition in the small intestines, where we have to give an enzyme called pancreatase in order to digest a little bit of fat in the diet, because fat just comes out. So you would see very bad smelling, greasy, that's the fat coming out in the stools. And because we're losing fat, which is a lot of calories, right? In every gram of fat, they're not going to be gaining weight. They're going to be on the smaller side, even though they're eating, but they can't absorb it. So they're not going to be at that normal height and weight. So how do we diagnose that little infant now? Not moving his bowels. All right. Hypothyroidism is one of them. Cystic fibrosis is one of them. Okay, let's do a blood test for the hypothyroid. And now let's do a sweat test for the cystic fibrosis. It's just these little tabs that they put on the skin and they measure salt on the skin. It's that easy, is the way it's done. Now, treatments, what do? Well, we got to treat the lungs. So if they're infected, we're going to give antibiotics. This child's going to probably have a PICC line most of its life, because they're on and off oral, inhaled, and intravenous antibiotics, depending on how severe this infection gets. These children are going to be on CPT, vigorous, with albuterol aerosols, opening up, clearing all of that mucus, okay? The other thing is, remember, with all of this aggressive chest physiotherapy and getting this mucus up, make sure we do it before meals, right? Now, before meals, get rid of the mucus, they can breathe easier, and then they're not going to vomit it when you're doing this therapy afterwards. Now, all right, with meals, these children don't absorb nutrients well, and they're going to need a pancreatic medicine, and the name that we use is pancreatase. It comes in many different forms. And what this does, it helps assist the body to digest. So we must take it 30 minutes before meals, which is like right as you're eating. Now, sometimes they're beads, never like an enteric, anything, chew or crush. If you need to, and they can't do a whole capsule, you can put it on a little food and they can take it that way. There's also powdered forms. If they do the powder, they must rinse their mouth. And the one thing I think we forget a lot is adjusting doses. Children go pretty quick, and sometimes they grow quicker than others, and then we don't increase levels, then they're not getting the nutrition. I see this a lot, like within children with seizure disorders, and all of a sudden they had a seizure, and we find out, oh, you gained 10 pounds, you need a bigger dose. same type of thing. So respiratory management, airway, CPT, physical therapy, physical exercise. One of the best physical exercise for this child is actually swimming underneath the water. Hold the breath, go underwater. You're giving yourself your own CPAP, if you think about it. Again, all in infections, it's aggressively treated oral, in the aerosol and in intravenous, which is the home IV therapy. When we talk about the nutritional section, talking about the small bowels, we talk about the pancreas. So if that is causing this really foul smelling stool and greasy, we're going to try to say, let's decrease the amount of fat intake, increase protein, high calorie, try to get as much, nutrition in the smallest amount that we can. Sometimes, it causes that constipation like it did at birth. Always, watching stools, and watching as reflux or anything. But the big thing, diet, high protein, high calorie, giving those enzymes right before the meals. And again, following the weight, making sure that we're nutritionally, we're doing the best we can. Now, off the Hesse was a question regarding pregnancy and cystic fibrosis. So, two ways that I know pregnancy with cystic fibrosis is male or female, right? Well, females can get pregnant. Yes, it is a high risk pregnancy, but they can. Now, men cannot, with cystic fibrosis, impregnate a woman. There's something with the vas deferens and the ducts and mucus, and it's clogged and it can't get the sperm to the woman. Okay. But 1 year post bilateral lung transplant, miraculously, I don't know why, they're able to father a child. And that's what your book says. Sleep apnea, anybody know anybody who snores? Well, children do too. It's the same treatment. We see children not sleeping well, and then they're sleepy during the day. They're going to need something to help them so they rest better. That sleep study, doing that surgery, adenoidectomies, BiPAP needs to be done. Okay.
I have a
And
question
again,
about that.
sure, good.
If a child has sleep apnea, are they going to continue to have sleep apnea through like their life, or are they more likely to get it when they're older?
Well, that's a great question. Does your child still have tonsils and adenoids in? Is it structural?
So
It could,
it could, yes or no, depending on the.
remember the necks are shorter. I don't know how heavy or thin. I'd have to, look more the individual on your child. Is it going to get better? It can. But usually, if they detect it early, it's usually because adenoids, tonsils, and mucus, is an ongoing issue. Okay.
Thank you.
No, you're welcome. So ARDS, and I mention this because respiratory distress, which means this is probably your sickest child in the unit. Remember, airway. No airway, you don't live. So it can be caused by many things. It could be sepsis, infection, overwhelming infection, trauma, drug overdose, and near drowning because you've damaged those lungs. Extremely high mortality rate. Now, I put the picture up here. That's an ECMO machine. That's what a newborn infant who wasn't breathing well at birth would be on that machine giving oxygen to them. And it goes into their neck. I had the privilege of being certified to work those things. And it's fun to see how it works and then taking them off and decreasing it and following it. For me, things like that are fun. CPR was on your last exam. Remember, one man CPR is 30 to 2, and one man is 2-man is 15-2, and we always start with chest compressions. And now also CPR. Don't forget, you have parents or guardians. We have sometimes siblings. Don't forget them during any sort of stressful situation like CPR. Okay. Asthma. How many of you asthma or know somebody with asthma? Very common thing. Now, we talked about croup. It's all upper airway and inspiratory, right? What is asthma? Well, something's gone into your lungs, inflamed the alveoli, and they clump down. And when air gets down there, it's stuck and you can't get it out. So it's expiratory. Oh, you'd hear wheezing, expiratory wheezing. Inspiratory croup, upper airway, lower airway, expiratory. Now, with asthma, of course, it's treating them, finding out allergies and all that good stuff. Keeping them normal. Again, it's having their little rescue with them, avoiding those big allergens. If it's something that they're really allergic to, you wouldn't put, if they're allergic to grass, you wouldn't put them in soccer, or something with grass. Maybe you'd put them in something else that would be just to keep them normal. And of course, with asthma is the prevention of any sort of asthma attacks. Now, that bottom three, orange, pink, and blue thing, those are the spacers that the mask goes up around the mouth, and then you put the inhaler in the back and squirt it, whatever the dose is. For young children, it works great. And yeah, they cry. But you know something, when they cry, they're getting deep breaths of the medicine. They get used to it after a while, don't they? Like this little kid here. So asthma, we're going to be giving the rescue. We're going to be giving those things that we have to give morning and night with that little bit of steroid. In children is something called Pulmicort, and that's preventing your bronchospasms. Then you have your albuterol, Proventil, Ventolin, whatever the name you want to call the name. They're all the same for rescue there. Then we have steroids in those emergencies. Now, status asthmaticus is when you're giving aerosols, giving steroids, you're doing everything, and they still can't breathe. Now, I didn't see a really horrible one that I couldn't break until my husband a couple years ago. He was in the ICU for 12 days with status, and he every day was fighting to breathe. And I got to see the whole progression of the way they treat it, and then put him on aminophylline and all different sort of aerosols and whatnot. But he never had to be intubated because I held his hand, and he's not been sick since. So let's knock on wood together, because that was pretty scary. COVID, we all know about COVID. This is up in front of us right now. Again, it's viral, and immunizations is what we need to do. Okay, hearts. So heart defects, they can be either congenital or acquired. When we talk about children, most heart defects they're born with. It is congenital. There's a bunch of different ones, from very minor little things to really severe things. I'm amazed that the normal heart is normal most of the time, because it literally is a stalk that turns and twists and wraps and goes around each other and twists by the end of fetal development. I mean, and it gets to look like that when it's done. And they're all almost the same, except, those congenital defects, right? Then as a child gets older, there are other things that can happen, and it could be acquired. It could be an infection, viral cardiomyopathy. You've heard that word before somewhere, I'm sure. The virus attacked the heart muscle. Autoimmune, what about lupus? Attacking the heart. We have cardiomyopathy. It could be the environment, of course, and that familiar tendencies always is play there. Now, do you all remember how to trace a drop of blood through the heart? Do you all know where valves are? Let me go over briefly, okay? So I'm going to start with the blue blood. That blood just gets back to the heart on the right side to superior and inferior vena cava. It goes into the right atrium. It goes through the tricuspid valve into the right ventricle. And then it goes through the pulmonic valve into the pulmonary artery and the lungs. It comes back to the heart through actually 4 pulmonary veins into the left atrium, through the mitral valve into the left ventricle, through the aortic valve, and to the aortic arch, into the aorta, and to the body. So you've heard the valve names. They're going to be important. Knowing right-sided, left-sided. When I tell you it's right-sided, it doesn't mean aortic valve or mitral valve. That's left-sided, okay? So these are the way to remember. Now, one of the conditions that I'd like to describe to you, you got to pay attention carefully here. Now, think of a garden hose. And if I kink it here, behind it, towards where the water came from, it's going to squirt, or something is going to go that way, right? If it can't go down, it has to go backwards. That's a concept I want you to think about. Here's your aorta coming off the left ventricle, past those 3 little vessels going to the brain, subclavian and the carotids, right? And it goes down the arch. At the arch, let's say it's inked really bad, and only a little opening is left. What's going to happen? What are you going to see? This is called a coarctation of the aorta. Well, if blood can't go down the aorta, what do you think is going to happen to the pulses on the feet? Maybe nothing. Maybe just itsy bitsy, but it's going to be decreased or no pulses in the lower extremities. Now, when you look at the upper extremities, oh, they're going to be bounding because more blood is going up because it can't go down. So you're going to have no pulses and bounding. That's first thing. Now, the next thing, what's happening to this blood? It can't go down. Yeah, it's going up a little bit, but it can't take all that blood. It goes back into the heart, into the left ventricle, stretches it, goes into the left atrium, and it goes into the lungs. And that's a place where it just can fill up. So now you're in congestive heart failure. Did you follow that concept? It's a big one. So if I got a child and I'm feeling pulses and I don't feel any pulses on the lower extremities, dorsalis pedis, posterior tibial, what would be my next thing to do to say this is coarctation of the aorta? I'm going to take a 4 extremity blood pressure. Because blood can't get down there, the lower extremities are going to be lower. And because extra blood's going up on the upper side of the body, the upper extremities are going to be higher. Make sense to you? Okay. So this is what you see. You know, when you talk heart failure, you're talking about many conditions. I just described coarctation and then going into congestive heart failure. But many of these other conditions do the same thing, and they just go into failure, okay? You don't have to know all of those things, but you just have to understand what I've just talked to you about, the kink and blood filling up the lungs, okay? So what are you going to see? Now, I had a little girl who came in with coarctation. I remember she was 2 or 3 months old by the time she finally got to us because nobody could diagnose her. Because pediatric cardiac is nobody, very few ERs understand it. It's just a very specialized area. So this little girl came to me. She was really hard. She could barely eat. She was tachypnic, tachycardic. Because fluid in the lungs, she's not oxygenating. Her heart's trying really hard to get oxygen around. She's not gaining weight because she has no energy, no activity intolerance. She can't eat. She's not gaining weight. You're not putting fuel in the tank. Cognitively, she's delayed. She's not even lifting her head. She's not even trying to grasp my hand. Something's going on, right? Now, one of the diagnoses that we could give this child: inadequate oxygen perfusion leading to activity intolerance, resulting in diminished energy to breastfeed. That's a great diagnosis for this child. It says everything. When you look at cardiac, you can just look at them. Sometimes you can put your hand on young newborns and you can feel like these murmurs after you work it for a while. Clubbing of fingers isn't something you see till later on with a cyanotic heart condition. I'll go into that in a little bit. When we look at children and cardiac children, they're going to be put on a monitor, and we want to know their respiratory rate and their O2 saturations. And then we're going to be doing an echocardiogram, trying to find out what's going on with the child. When we determine there's a problem with it, the child's going to go for a cardiac catheterization. And that cardiac cath is going to show the surgeon where these defects are and what they need to do in order to have the best cardiac blood flow you can have. Sometimes it's not to make it perfect. Many times it's just to give it the best blood flow, the best oxygen that they can. That would be, one of them. Another cardiac cath that we do usually later on, not the newborns, is that child who's having these little times where the heart rate speeds up quick and then slows down. It's like all of a sudden they can feel their heart flutter and then it stops. And it's got to be the point where they're seeing a physician, they're on medicines, and they want to do a permanent cure for it, and they can. And they do that with what we call an electrophysiology study. What they do is they make the heart start to beat fast, and they find where in the right atrium, because the right atrium is where heartbeats are originated, right? CSA node, but anywhere the right atrium. Good, that's what's happening there. All of a sudden they figure out where it is, and they take a laser and they zap it. And these children, after a couple of months, they're off all meds and they're fine. So cardiac cath. What do you need to know? How are you going to take care of that child pre and post cardiac cath? Well, the prep to go to cardiac cath for older kids is just NPO and send them. Newborns, which is most of the children with congenital defects, is take breastfed baby and feed them up to about 2 hours before we do procedures. We don't want them to be without sugar or food, and it does work out well. When they come back, you have to remember these children have had 2 big catheters put in their right femoral artery and right femoral vein. And they've pulled them out and they've applied pressure so that it's not going to bleed. Then they take and put a pressure dressing on it, and old children, they'll put a sandbag on it. And they take the child, put it back on the stretcher, the bed, the isolette, warmer, whatever they came in, and bring them back to the room. The first thing I am going to check, of course, they're pink, they're breathing. First thing I'm going to check is their pressure dressing. If you can imagine, something the size of your pinky and how quickly blood could come and exsanguinate a newborn infant, you're going to look at that dressing very quick. I've only had one I've ever found that was bleeding, and I caught it quick. But can you imagine how much blood could come out? So check dressing first. Hemorrhage is your biggest risk in a cardiac cath. Nothing else, it's a hemorrhage. Then you can go ahead and do your vitals, check your pulses. Probably that right leg's going to be slightly diminished, normal. You just had big catheters in there and inflamed it. And you're going to be giving either fluids, whether it's IV or offering orally, and then we'll do a blood glucose. We want to make sure, did they get any sugar anyway in the cardiac cath lab? They usually don't have sugar and fluids there. So making sure that their sugars are good. They need sugars to work. Now, congenital heart diseases are more than I ever thought. I never knew, until I started working in the cardiac ICU. There are 5 to 8 per thousand, and it's the major cause of death in the first year of life after prematurity. And I want you to know that I know when I first started seeing some of these diagnoses till now, outcomes have completely changed where they would never do anything, send the baby home. Today, we're doing 3-stage surgeries and we are repairing these children to live a fairly decent life. So big changes. The biggest, most common is a ventricular septal defect. That's just a hole between the right and left ventricle. Be small, medium, or large. They're all different. And know that Down syndrome are the ones that have the most congenital heart defect. We know VSD is, we always listen for that when we think of Downs. And there's a couple other diagnoses I don't want to tell you about because they're just another name you don't need to know. Now, congenital heart defects can be whether you have oxygen or not. You're going to say not. Yeah, sometimes there's not. You just give them the best they can have, all right? And you'd be surprised. They can live on O2 saturations of 75, 80, okay? Little newborns. Sometimes I've seen it down to 65, depending on the defect, all right? And when you're acyanotic, you've got all of your O2. Cyanotic, you are, as I said, be down to O2 sats of 65. Always know that blood, just like the mucus in the oropharyngeal area goes into the ears as areas of least resistance. Shunting is the same thing where if you have high pressure and low pressure, blood's going to go from high pressure and go where it's least, all right? And if we look at the heart, where is low pressure? Blood just gets back to the right side. It's low pressure. And then you got those 4 veins putting blood in that left atrium. That's high pressure. So blood coming back from the heart, from the lungs into the left atrium, because sometimes there's an opening left there at birth, or it's an ASD or a patent foramen ovale. Blood goes through and it's reoxygenated. So ASD, VSDs, all of them can have increased pulmonary blood flow because it just keeps circulating it because there's a hole there. They need to stop it or they need to get older and it'll close by itself. Now, there's something called a patent ductus arteriosus. This is a concept that students find difficult. This is what keeps babies alive in fetal circulation. I call this the oxygen giver. It connects the lungs to the body, the aorta, pulmonary artery to the aorta, 2 big vessels. So I'm going to give oxygen from my pulmonary artery, lungs. Whoop, I'm going to give it to the body. That's when something else is happening and the body's not doing it by itself. We went over coarctation of the aorta. That causes congestive failure, backwards, decreased blood pressure, lower extremities, increased upper extremities. Whenever you see a stenosis, it's always a narrowing. An atresia means there's nothing there, as in there is in tricuspid atresia, there is no opening between the right atrium and the right ventricle. Well, how's blood going to the lungs? Pulmonary artery is in that right ventricle. There's no connection. This is one of the diagnoses that needs an oxygen giver until we can do surgery, the PDA. Keep it open. We're going to go in how to do that or how to close it in a second. Now, one of the diagnoses that you're going to see a lot, it's on the NCLEX, I've seen HESI. It's just a diagnosis that I like to use. It's a cyanotic heart disease called tetralogy of Fallot. Tetralogy of Fallot. Anybody ever hear of a tet spell? Blue baby. It's like all of a sudden they turn blue. Well, tetralogy of Fallot is a right-sided condition where the pulmonary artery gets kinked or something goes over it, and no blood from the right ventricle can go to the lungs. And it's called a tet spell. It happened to me once in my career. It was 4 or 5 o'clock in the morning. It was a little baby, less than a month old, little Nolan. I remember his name. And he went from a sat of 100 to 10 in about 2 minutes. So know with tetralogy of Fallot, the treatment that you can do is take the knees and the chest, pull them together. It's called a knee chest. Older children that have not been fixed will squat to the ground. And what it does, it changes the abdominal cavity and the chest cavity's pressure, and it pops open the valve and it allows blood to flow. So tetralogy, that's what you need to know. Transposition of the great arteries. Interesting. And I need an oxygen giver there also. We have the pulmonic circulation and the systemic because they're switched. So there's no oxygen going. So we need a PDA till we can take it off, turn it around, and put it back on. And that's exactly what the surgeon does. Takes the top of the heart, turns it around, and puts it back down. And he's told me he has to watch out the coronary arteries. One might get stretched a little bit too much, so he has to be careful. I think it's just amazing. And just to let you know, the worst or the most, the one that's most severe of all these cardiac conditions is a hypoplastic left heart syndrome. That's when the left ventricle doesn't form and there's no pump. This is the 3-stage surgery, and many of them end up in heart transplants. But now they live, where back in the 80s, they didn't. So PDA, oxygen giver. Everybody at birth has it. Why? Mommy produces a hormone called prostaglandins, and it keeps open this duct that connects the aorta to the pulmonary artery and lets oxygenation go. Now, how would you know if that's open? Well, number one, there is a loud, I'm talking loud, washing machine murmur. Sounds about like that, okay? That's number one. If you're not saying, I don't know, take a blood pressure. And if it's a cardiac child, most likely they'll have an arterial blood pressure. When that diastolic is that low, at birth, 60/40 is normal. It's like 120/80 for you and me, adults. 60/40. At 18, it's telling me the PDA is open. So there are times we have to close that PDA, or normally it just closes. How would you know it closes? Well, the diastolic will come back up to where it was, and that murmur goes away. Simple as that. Whether it's normal by itself or if we need to give medicines, both of those. So prostaglandins keeps it open, and indomethacin closes it. You need to know those two medicines. They're going to be on an exam somewhere. All right, there's a couple things and looks at blood flow. I've left them for you to look at if you want to see the way the blood goes. I think I've explained it, but I left those slides there for you to look at. Okay, now we got that little child in congestive heart failure. That poor little coarctation comes to me, and that child really looks about like that. In fact, that kid looks a little bit fatter than the kid, my little girl, when I had her. Do an x-ray, it's full of fluid all the way up. What do we want to do? How can we help this child? Well, we want the heart to work better, and we want to get rid of all that extra fluid in the lungs so that the heart doesn't work as hard and that oxygen demands go down, right? Big goal. Well, how do we do that? Well, and then how do we manage? Is it working? Our treatment. Well, many times we'll just put these children on digoxin, just like adults, but it is mics per kilo per minute or milligrams per kilogram per minute. And it's an old drug, and we use it on brand new infants. Removing fluids and sodium, furosemide, Lasix, like we use on adults. It's 0.1 milligrams per kilogram. There we go. So there are ways to give these and get rid of fluids. Now, how do we know the child's getting better? Well, they're breathing easier. And then on our daily weights, we're going to see the weight. They're losing weight. They're losing fluid. And conversely, if we see weight going up on a newborn who's cardiac, you're going to be concerned about it going to the lungs. So daily weights, intake outputs are so important on especially cardiac newborns. So how do you give digoxin? Well, just like you do adults. Count the apical pulse for 1 minute. Check the electrolytes, specifically potassium. Check to see if there's a digoxin level. And then it's difficult to say, is my child digtoxic? Well, in an adult, symptoms, vomiting, nausea, the heart rate will be down, but seeing yellow spots and that vomiting thing. Now, children can't do anything but just vomit and show you, right? They can't say, I have yellow spots. No, they don't speak yet. So if you have an infant that's on digoxin and they're vomiting, I'm going to hold the dose, call the doctor, and ask for a digoxin level. It is better to be safe than it is to be sorry with digoxin. Okay? So all of this stuff, baby's feeling better, eating better, breathing better, and then it's trying to maintain it. Now, hypoxemia, as I said, there are conditions like the hypoplastic left heart syndrome that children, 3-stage surgeries, after third stage of this surgery, if they're over 90% oxygen, that's a good outcome. Sometimes they're 88, 90, right there. So there is a component of hypoxemia. And then, of course, they've been hypoxic with each stage surgery before it's been done. So there are conditions to look at. Well, the clubbing, that you can see that fingers are sort of round and squared. That would be an older child with clubbing. The other concept I want you to know is polycythemia. Why is anybody who's hypoxic have the capability of being polycythemic? What is the body doing? The body's producing red blood cells. What do red blood cells do? They carry oxygen. The body's trying to say, here's some red blood cells, here's some more oxygen, but there is none. So then it keeps producing red blood cells. So polycythemic would have an elevated hemoglobin hematocrit. You might have 18 and 54, not 14 and 42. Understand? More cells, be informed, trying to help. Body is a miracle in what it does. So we need with these children, of course, I want to know that during my career, I worked 10 years in this unit. And these families are so thirsty and they want to know all about what they can do for their children. And as I've always said, as I'm assessing the child, I'm talking to the child, but I'm literally talking to the parent, saying what I'm looking for, what I'm listening for, what I see, trying to get them ready to go forward. I mean, some of these children, like a hypoplastic left heart, have a long head of them. They really do. As I said, cardiac cath, the one things I didn't mention was bed rest for 24 hours, and you can't bend that right leg for 24 hours, fear of losing the clot. Bacterial endocarditis, this is, again, we're just talking about prophylaxis. And rheumatic fever. Now, you're going to hear on week 8 of another condition that can cause problems because of a strep infection. Now, rheumatic fever is something where a child's going to come in, has a sore throat, joints are swollen, could have this weird chorea type of movements that they can't control, and it could have rashing. And the one thing that we are concerned about is it can affect a heart valve, which is mitral valve. Now, once we figure it out, this would be a patient that we say, have you been sick lately? And if you, well, maybe, I don't know, a little sore throat or cough, they might do labs and they might look at an ASO titer. Ever hear of ASO titer? It's an anti-streptolysin titer. Strep is in there. It's measuring strep in the blood, and it can positively identify rheumatic fever. So if all of this stuff has occurred because of a strep infection that wasn't treated or partially treated, what do you think the treatment for rheumatic fever is? Long-term antibiotics, right? Until we get it. Now, if the heart valve was damaged, that's not coming back. It's still going to be damaged. That central nervous system chorea, that will, go away. All of the joints, rashes, all of that will go away. But the heart will be permanently damaged. Children can have problems with their cholesterol. They can have slow, fast, or irregular heartbeats. They can have issues breathing. It could have been due to prematurity. Could be with cardiac. Again, it's just they don't exchange oxygen well. And then, as I said, children can get these cardiomyopathies. A lot of times you're going to see it like viral. Again, it could be due to almost anything that could cause it. And I've seen these children, they come in and they get what we call these tune-ups and send them home, and then they keep coming in and out. And finally, the heart can't tune up and it's going to have a transplant. Now, the problem with transplant, the biggest problem is rejection. So they get a heart, they're feeling better, and then they reject it. Now, most children who have open heart surgery are going to come out and have some chest tubes. So how do we take care of these chest tubes? How do we get them out and do it in a manner that's the best way for this child? Well, you always take vital signs first and medicate for pain before. You're going to explain to that child on their level what you're going to do. And you need to be honest. I worked in adult open heart surgery ICUs, and I did the night shift. So every morning at 6 a.m., I'm with the residents pulling out chest tubes. These adults tell me it burns. And it's like for a minute, 30 seconds, and then they're okay. But let that child know. Remember, you lie to a child, they'll never go and trust you again. We do have children with high blood pressure, believe it or not. We're checking blood pressures younger and younger. Kawasaki disease. We call it a cardiac disease because it's a systemic vascularitis of unknown cause. What does that mean? The vessels get inflamed, and the ones that we're concerned about are the coronary arteries. Because if they get these little microembolus from this inflammation, it can cause aneurysms, heart attacks, and death. Okay. What do these kids look like? I mean, all of these little pictures are telling you that telltale sign. We have red eyes, we have red lips, strawberry tongue, cracked lips, cracked hands, blistered hands, palms of hands and soles of the feet, and then swollen glands. When it's diagnosed, treatment is intravenous immunoglobulins. We will need to boost that immune system. And we're going to put them on high dose aspirin. And you're like, aspirin? We're told not aspirin. Well, there's little microemboli in there with all of these little blood clots, right? And we need to prevent clotting. So it's either aspirin or Coumadin. Aspirin's the easiest of both to do. So usually it's aspirin, although it could be, as long as the blood is thin because of the blood clots. Shock, children, what do you see? Well, you're going to see decreased capillary refill. Your color is going to be horrible, elevated heart rate, decreased blood pressure, decreased mentation, depending on the child. Now, the most common fall shock in children is septic. But remember, we're giving medicines to these children, they're young, new children that have never had drugs before. So anaphylaxis is always a concern when you're giving a new antibiotic or a new something, which is high possibilities. As I said, septic shock, it's just catching it quickly. Now, how would a newborn tell me that they're getting infected? Very simple. They start having periods of apnea and bradycardia. They shouldn't be apneic and bradycardia, even if they're deep at sleep. When we start to see that, that's that first clue. And as nurses, we tell the doctor, and then we do the whole workup, start antibiotics before there's ever a problem. Toxic shock, that's your adolescents, that's the tampons. So surgical closure of the patent ductus arteriosus would result in which of the following? Oxygen giver connects pulmonary artery and aorta. Going to prevent oxygenated blood from going back to the lungs. It's not over-circulated. It just tends to overflow it and causes acidosis if we let it go there too far. So anyway, any questions at all? All right, I'm going to start the cahoots. I understand if we don't get all the way through that at 20 after, if you need to go, you may. I won't yell at you. I don't yell, period. This is, again, another important cahoots with the amount of concepts here. All right. You can still come on. I'm going to get going. I'm going to try to get through this. I'm going to hit some quick outs, but I want you to get the information. A majority of upper respiratory infections are caused by, I think this frustrates mommies all the time. Your child is 104 fever, runny nose and cough, bring him to the doctor. They tell you it's an upper respiratory, it's a virus, no antibiotics, and send you home. And you wanted those antibiotics, but most of the time they're viruses. Most, okay? Not infectious. Multi. Down's children are susceptible to which medical conditions? Mentioned this today. I saw this as a question somewhere. At this point, I don't remember where. Poor little Downs kids, some of them dear to my heart. Taught them when I was a teenager. They have problems with their thyroid, leukemia, and congenital heart defects. I'm sorry that's not checked there, but yes, it is. You walk into a 6-year-old's room and you find them not breathing and doesn't wake up. What do you do? Number one, number one is chest, and then it's airway later. Years ago, they started airway, but they realized oxygen was left in the body. So just chest compressions, and then right above the bed, hit that code blue button. Get people to help you. Multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? And I could say not just respiratory infection, that they're sick. Fever, poor appetite, vomiting, abdominal pain, sitting in the corner, not their favorite juice, nothing. Again, the important part is get the fever down, hydrate them, because when the fever's down, they'll eat and they'll drink, which is what you need. A multi. What do you look for when assessing respiratory function? We look a little bit of everything. The one thing with children, you can actually look at them with your eyes. You'll know if they're in respiratory distress. Infants, there'll be nasal flaring, and you'll hear like this grunt at the end of every breath. It's just what they do. And you could see retractions between their clavicles. That's the telltale sign that they're really struggling. What would you look for after a child has a tonsillectomy? What's your concern? What are you be looking for here? Swallowing more than usual. What would that tell you? This child's bleeding. Now, you're not going to put anything in their mouth, but they can open their mouth a little and you'll probably see bright red blood in there. Remember that little girl that I told you, 7 days post tonsillectomy? I had to rush to the trauma room to give her 1,000 mLs of fluid. She was 7 years old. She was that bad. Multi. Nursing care for a child status post tonsillectomy include so give them their pain medicine as they need. Of course, no spicy food. Gum, yes. Remember, the older kids, their ears pop. They get congested. It's like going in an airplane. They can help their ears pop. And the ice bag, if they let you, it does work. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? This is called bronchitis or tracheobronchitis. Asthma is not a dry, bothersome cough. It's a cough, it's expiratory wheezing. There's a lot more to that. When you see dry, bothersome cough at night, that's always bronchitis, tracheobronchitis. Multi. What signs and symptoms would you see in a child with otitis media? They don't always have fevers. You caught that one good. Ear pain, yes. In fact, when you have a child with otitis media, your priority is to get them something for pain because it does hurt. The monthly immunization for RSV. Remember, we give it for the first year of life from winter to early spring once a month for those immunocompromised children that extra mucus would be too much on them. And it's called Synagis or Pavizumab. Very good. A 4-year-old child's been taking meds for asthma. Child is still wheezing. Information is important. What do you need to know? Something's wrong there. They're taking their meds. Why are they wheezing? And it could be as simple as the MDI without a spacer. If they're wheezing and they tell you they don't have an MDI spacer, you can go grab a spacer and tell the doctor I'm going to give them a spacer, and I go, please, so you can send them home with what's going to work there. An 8 filled with croup exhibits what signs and symptoms of respiratory distress? Put this question here for a reason. This has different numbers, which is normal for an 8-month-old, right? Remember I told you that vital sign sheet? You have to sort of figure out what's normal and not. Well, the pulse rate of 108 is normal. Respiratory rate, that's actually perfect. Abdominal breathing pulse of 100, looks pretty calm to me. And the O2 sat 95, absolutely above 90, you're good. It's that now, that restlessness, hypoxemia, and of course the retractions. Signs and symptoms of asthma include all except. Which one of these is not asthma? You do have a cough, you do wheeze, you are short of breath, but there's that prolonged expiratory phase. Remember, when you have croup, it's all upper airway, it's inspiratory. Once the air gets in with asthma, it's stuck. It can't get out. So it's a prolonged, like, trying to get that wheeze, trying to get the air out. That's what they sound like. Signs and symptoms of congenital heart disease include all except. You got an infant, congenital heart disease. So the weight gain's not going to be appropriate because they're not going to be tolerant of feeds, etc. Very good. What should you not do to children diagnosed with croup or epiglottitis? Again, anything oropharyngeal, tonsils, croup, epiglottitis, nothing in there because you don't want to increase swelling. A multi. Treatment for infectious mononucleosis. Let's go riding an ATV in the Everglades. So remember, it's an Epstein-Barr viral thing. Antibiotics aren't going to do anything. It is acetaminophen, ibuprofen, rest, fluids, and protect that belly, please. Bye. When doing an admission on an infant with a low-grade fever, a loose cough, what information is important? So you're bringing a kid into your floor and you're doing an admission, and those are your symptoms. What do you need to know in order to place that child? What's important there? I've mentioned it in many different ways, and it's that immunization status, number one important, because if they don't have immunizations with that, that child's going to go in a room alone just to be safe, right? The highest fever, yes. And of course, medications and the medications so that I can continue giving antipyretics. What's the greatest risk for an infant having a cardiac catheterization? So again, cardiac cath, remember, they can bleed out. Very good. How is cystic fibrosis identified? So we know that there's newborn screening now, and the only reason why I know, my daughter actually just started third trimester, so I'm excited having another little boy. And then there's a sweat test at birth, and that would be no stooling, and then that would make us check, or maybe even later on, we're starting to see symptoms of it. Say, what is included in the plan of care for a child with cystic fibrosis? So remember, cystic fibrosis, multi-system condition. I met one family who had 3 boys that had cystic fibrosis in the same family, and one was a cardiac. So it has to do with your chest, your lungs, and nutrition. Aggressive CPT, high protein diet. You need that high calorie, carbohydrate, low fat diet. You'll never, ever hold a salt shaker from a child with cystic fibrosis. Lick their skin. That's where all their salt's going, right? And of course, pancreatic enzymes with meals right before it, 30 minutes at most. What is the drug of choice for pharmacological closure of the PDA? Now, as I said, it'll close when baby's born because mommy's prostaglandin is gone. So after mommy's prostaglandin is gone, we give indomethacin. Now, indomethacin closes it up, okay? So prostaglandin keeps it open. Mommy has it, or we can put a slow continuous drip, or if we want it closed, we can give indomethacin, and it's usually 3 doses that we give over a period of time. What is not a feature of tetralogy of Fallot? And my answer is this is a right-sided condition. Which one here is not right-sided? Your aorta is on the left side. All the rest can be right-sided, okay? That's the key that I want you to remember. All on the right side for tetralogy. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, and 32? Again, that's your digoxin. Sometimes it's only vomiting you see. Again, be safe, not sorry. Why would a child with tetralogy of Fallot not gain weight at the normal rate? And you could take that tetralogy and put any congenital heart defect type thing in there. It's because they have decreased energy because they don't have enough oxygen. All are examples of cyanotic heart murmurs, except sort of tricky here. So remember, osis is a narrowing, and atresia, there's nothing. So I gave you that. You know what tetralogy is. So tetralogy is cyanotic. Tricuspid is there's nothing going into the lungs. Aortic stenosis and an ASD are both, you're still oxygenated. Nursing care following a cardiac catheterization. So again, number one, let's check that insertion site. We're going to keep that leg straight, 24 hours in the bed, slowly elevate and get them something to drink or IV fluids. Multi. Nursing education for the cardiac catheterization include all except so they can't ambulate and they can't bend that extremity. Yes, we'll be watching vital signs and of course that dressing. Which information is most important when rheumatic fever is suspected? So remember, rheumatic fever is caused by a strep infection. It can be completely wiped out with long-term antibiotics, except the heart valve that was damaged. It's damaged, it's damaged. It will not come back. Signs of shock in children include all of the following, except so you have low blood pressure, you have high pulse, altered mental status, and you have poor capillary refill. Hypertension? No, 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 no. Which of the following best describes the pathophysiology of Kawasaki disease? You know, the director of the cardiac ICU's son at age 3 was admitted with Kawasaki. One night while I was on duty, guess who got to take care of this child? His eyes looked like that, bright red, and I had never seen it before. Something you don't forget. But remember, our concern with Kawasaki is that multi-system vascularitis, which is little microemboli, and you can have aneurysms if it gets blocked. It's a serious condition. You know, thank God his coronary arteries were fine. He did great. He plays pro baseball now, that little kid or something. But again, it's be concerned. This is a child who gets aspirin and IVIG. So a clinical manifestation of Kawasaki is, what do you see? You know, working in the emergency room and seeing children come in with fevers and rash and, you know, just the beginnings of Kawasaki and try to diagnose it used to be fun for me. I enjoyed doing it. Um, and Korea is rheumatic fever, right? That's the difference. What is the treatment for Kawasaki? Aspirin and IVIG, and maybe not aspirin but Coumadin, but according to you, it's aspirin IVIG. Which of the following is the most common cause of shock in infants and children? Children, most common. Infection, sepsis. That's the one that it overwhelms them. There's no immune system. So that's the one that puts them in shock and very ill. What are the defects associated with tetralogy of Fallot? Right-sided. Good job. Yes. Pulmonary stenosis, right-sided. VSD is right on the right side. the aorta gets pushed over into the right side, and then that right ventricle gets stretched when blood can't go up into the lungs. A young child with tetralogy of Fallot may assume which position naturally when having a TET spell? I was like, why are all children fixed if they have tetralogy? That's dangerous, right? Well, there are some children that aren't done till they're like 2 years old. And what they do is naturally they just squat and it pops it off. It changes that pressure. It works. Transposition of the great arteries. You know what's amazing? Most cardiac conditions does not mean there's going to be cognitive delays because of their conditions. It's that hypoxic episodes which can cause those things. Now, transposition, you have to turn them up, put them around, at the top of the heart off, turn around, put it back on. Arterial switch, it's what it is called. And it's a procedure actually that we don't do for about a week after birth. These children are placed on that oxygen giver or that IV continuous prostaglandins, the PDA. And these children are actually given to parents to feed a bottle the first week with transposition of the great arteries. And then a week old, do surgery on these children. It's quite impressive, actually. Which of the following is not an intervention indicated for transposition of great arteries? Well, know that if we're going to do something, it is big. There's nothing little about transposition of great arteries. And what I mean by that is oral vasal, nothing. It's not going to work. It's the prostaglandins, oxygen giver. Arterial switch is the name of it. And then the other thing, and we do it at bedside, it's called a balloon atrial septostomy. Sometimes it needs some more combination between the left and the right side of the heart, oxygen, non-oxygen, right? And that patent foraminal valley at birth, that little hole on the atrial side, what they do is they make it a little bigger and they let blood flow. It's like an extra PDA, but it's in the heart. And they do that right at bedside. Again, big stuff, transposition. Multi. Why is prostaglandins given to the child with transposition of the great arteries? It helps with oxygen and it maintains cardiac output. Prostaglandin is a hormone. It's not an antibiotic. It has nothing to do with infection. It's an oxygen giver. It keeps the PDA open. What is the purpose of giving indomethacin to a neonate with a PDA? Why do we want to close an oxygen giver? That's what that's saying right there. And how does indomethacin do that? Indomethacin, indocin, same name. And what it does is sometimes after birth, for some reason, the PDA keeps open. You see this a lot of time with the premature, small, it's these premature infants, and the PDA just keeps open. Why is there still prostaglandins there? Who knows, but they are. So what we do is we give this IV medicine, 3 doses, a certain amount of time in between, and it says, stop prostaglandins, close it up, we're done with you. And we see that murmur will go away and that pulse pressure will go back to. Where is the patent ductus arteriosus? Oxygen giver, where are you from? It connects the aorta to the pulmonary artery. Talk big, big things, right? We want to get oxygen, pulmonary artery, and we want to give it to the body, the aorta, okay? This heart defect allows blood to pass from the left ventricle to the right ventricle. What is it called? It's called a ventricular septal defect. Now, if it was between the atrium, it's an atrial septal defect. A multi. What is a sign of digitoxicity in infants? You would see that maybe retching, nausea, vomiting, and a heart rate low. I knew somebody would say seeing yellow spots, but I'm sorry, an infant can't tell me if they're seeing yellow spots. And DIG has nothing to do with an infection. It has to do with decreasing the heart rate. Left-sided congestive heart failure causes what? That left side of the heart, that left ventricle ain't working. And it's going back and it's going up into the lungs, right? All of that stuff, left-sided. Again, that's why you need to know blood and the heart and the valves and where things are. It's all about the lungs are filling up and you can't breathe, and all the symptoms to be with that. After a heart transplant, what's the leading reason children die? Rejection. It's not infection. Rejection. The body says, no, I don't like you. A multi. Signs and symptoms of rheumatic fever include, remember, due to a strep infection. You might have to do the ASO titer to find that strep. So it's a little bit of everything. And remember, in rheumatic fever caused by a strep infection that wasn't completely treated, everything is reversible, even the central nervous system chorea. The only thing that's that cannot be turned around is heart valve problem, and that's giving long-term antibiotics to treat the strep. A multi. A child's just about to have a chest tube removed. What would you do? Explain it to them. Tell them it's going to hurt. Always, always, always medicate before the procedure. And you're not going to be supine. You're going to have them, semi-Fowlers, elevate the head of the bed for that. A child has just had abdominal surgery, cannot cough well enough to expectorate secretions. What's the nurse's priority? So they're basically saying, how are you going to make this child cough? And they just had surgery on their tummy. How are they going to cough? Number one, medicate them for pain. I'm not going to cough if I hurt, right? So again, think back from the beginning. Medicate them for pain. Get them out of bed, cough deep, breathe in spirometry. All that stuff will work. First of all, medicate for pain. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Never, never, never give anything but acetaminophen till 6 months. Then you can give ibuprofen. A newborn infant is assessed and you find very weak lower extremities. What should you assess next? Do that for extremity blood pressure. What are you going to find? Lower extremity in the lower extremities, and about 20 or more millimeters of mercury up on the the upper extremities. Very good. multi. A critical ill child is on complete bed rest. What can a nurse do to prevent complication? Now, you think children are not going to get sick. They're not going to have all those things that adult has, like decubituses and bronchiectasis and blood clots. And you don't think children will get that, but you know something? They do. So we need to do things like turn in position every 2 hours, elevate the head of the bed if we can. That's why I don't have it there. Some you can't. Keep them dry, get their lungs moving. Another thing is pillows, blankets, and I use those little beanie babies on especially small infants, have their endotracheal tube so that when they open their eyes, they see the little beanie babies and they're hugging their teddy bear, or maybe have another one between their legs or behind them. And I have them propped all over, like, where's Waldo, in the amount of stuffy toys that I use on them. And the parents love it. Whatever, keep them over, pillows, blankets, anything. How can oxygen be delivered that is the easiest tolerated and strictly monitored for infants? Absolutely the oxyhood. They love it. Blow by tickles them. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? The lungs are full of thick, gooey mucus, and it's going to require a lot of deep breathing, coughing, chest physiotherapy, exercise, not just PRN ambulating. They need to be up and as much as possible. I mean, a lot of aggressive chest physiotherapy. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? This is even a question right off your NCLEX that you might see. And again, take them right before meals. The capsule you can sprinkle, never crush or chew those little circles, those little bead things. Powder, make sure you wash your teeth, or those teeth will rot the enamel. And again, increase the dose as the child gets bigger. What is a cardiac defect where there is no valve between the right atrium and right ventricle? See if you remember. Tricuspid atresia. Very, very, very good. And last question, you made it. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? Think is going on? Probably it's the breath sounds. If they're breathing fast, tires easily, they're not getting oxygen, could be congestive failure going on. So it is breath sounds. Let's see how we did here. Tammy, good job, Tammy. Autumn. Whoop, whoop. Can I get more excited than all of you? Monica, good job. Dan the man and me. So we are done with week 5. You got everything you needed there. Anybody who needs help, let me know. And know that that matching I gave you, and I give the one that had all the answers. That is your guide. Understand it. If you don't, come to me. I'll help you with it, okay? Good luck, everybody. See you all next week. Any problems, concerns, anything, let me know, okay? Keep me in the loop. I can help. If not, yeah. Bye, guys.